know they give me the toughest job because you guys just had your belly full, you just ate, and now I have to come up and get you guys to wake up all over again, right? My name is Sana Joseph Smith, and I'm one of the governor's policy advisors. And so it's a pleasure to be here with you all today. And so before we kick off our next session, we just wanted to see how many of you were awake during the morning. Pop quiz. She didn't tell you about the pop quiz, right? So what nugget did you get out of this morning's sessions? Tell me just a little something. Raise your hand. Now, you know if I know your name, I'm going to have to call you. So somebody raise your hand. What's a nugget? Let me give you an example. So one of the big things that I got, I know this might seem a little strange, but what popped out at me was the visual that Dr. Ford, my good sorority sister, I knew she was good people the minute I saw her. But she showed a visual of the difference between equality and equity. Did y'all see that visual with the boxes? Now, I thought that was just a great tool. We have this conversation a lot in the Virgin Islands, especially when it comes to our position during COVID, because we're still feeling the impact from the hurricanes. And so just because we all got a same amount of funding, it just doesn't impact us the same because we were already, 2 boxes below other people. So that was really something that jumped out at me as simple as that. So I just shared my nugget. Who's gonna help me? Oh, there we go. The silos. Working together and the silos that are happening. Very nice. I mean, how many other people are experiencing that? Yes, definitely. Who else has a nugget? Yes. Social determinants of health as a community issue. I like it. I like it. All right. Can I get 2 more? It's like your pastor. Can I get 2 more? 2 more. There we go. Yes. If you want to travel fast, go alone. Aye. All right. And you have one. All right. We're much stronger together. Definitely. See, I knew you guys were awake. We have one more? Oh, okay. Go ahead. Yes.
One of the excluded areas is behavioral health.
Behavioral health. I mean, that's been the hot topic everywhere. I think that what we definitely need to continue the conversation. Oh, where's Commissioner Encarnacion? I'm gonna steal her words because she shared with me right after lunch when I told her I would pick on her. She didn't. No one raised their hands, and see, she didn't even show up. But nonetheless, I'm gonna share what she shared, and she said that we're at a point now where information technology in the health world has increased so much that at some point we've got to get it where the practitioners are connected. There's a gap between all this information, all this technology, and the people who actually have to deal with I want to say customers from my business, but the patients. There has to be a connection, and we have to close the gap so it doesn't. And we had another conversation as well with Mr. Malloy that it doesn't make sense if we have all this data and we don't know how to apply it and make it practical and impactful, right? Did you want to add to what you said? So he's saying, oh wait, go ahead with the mic. I'll let him repeat it so that I don't have to put words in your mouth.
IT systems are not developed for IT's sake. They're designed or implemented to solve a business problem, to a solution. So we have to move away from the notion that IT systems are as a technical. I don't usually like the term IT projects. IT. It's for a purpose, and focus on the purpose rather than the tool that's being used to solve that.
Definitely, thank you. Anybody else have any burning things they want to share about what they've learned? Oh, you heard me talking about you, right?
I had to come to defend myself. One of the things that Dr. Ford said this morning, and I think we need to really learn from that, is having to do with the cell phones. To me, it's just a simple concept. We have, like the cell phones, we have Apple, we have, That's the only one I know. I'm just teasing. But if we create systems that can actually come together to exchange, that's kind of like where we need to go to. So when it comes to health and when it comes to equity, we need to figure out how we decrease barriers and increase access to care. And the notion of what we could do with the cell phones is that's one of the things I think we need to challenge. So that was one of the things that stuck with me this morning.
Awesome, awesome. All right. So thank you so much for your input. It sounds like we're awake and we're ready for our next session. So coming up next, we have Ms. Ryan Argentieri, and we also have Alex Mugg, and they're both with ONC. You've heard many of the other presenters mention ONC, and now you'll actually get to hear from two ladies that are representing the organization. So we'll transition straight to their virtual panel at this point.
You all can hear me. And you can hear me because I hear my let's turn it down so that I don't hear myself. All right, apologies for that. My name is Alex Muggy. I am here with Ryan Argentieri. I'm actually from the Centers for Medicare and Medicaid Services, CMS, but we work so closely with ONC that we really are practically partners. My role at CMS is that I'm the Chief Health Informatics Officer, and my team oversees the interoperability and health IT efforts that are happening at CMS. And I had a lot of talking points to share with you guys today, but in hearing some of your nuggets and insights from this morning, I had a couple of additional things I wanted to add. So not sure if the slides are up on the screen, but we do have a few slides to share with you. And if we can go straight into, I think, the one right after the intro. And I'm not sure if I'm supposed to be the one advancing them, but I don't have a way to do that. So hopefully that's happening in the room. Beautiful. Thank you so much for that. So again, I am from the Centers for Medicare and Medicaid Services, or CMS, where we regulate a variety of providers as well as payers. We have a significant footprint in the healthcare market, and that's why we think that we are optimally positioned to support interoperability. And that's what we're here to talk about today. We believe that better access to health information can improve healthcare decision-making, and it can also lead to better health and health outcomes. So as you can see on this slide, this is just a generic slide to have up in the background, but it really is about all of the different streams of data coming together so that we can gain insights about a person's health. I heard a couple of you earlier talking about your nuggets and that you believe that we are stronger together, and I couldn't agree more. I think not only is the healthcare market better if it's together, but also data is better if it's together, and it can provide much stronger insights to patients. I also heard you say that there's so much data and so much IT, and it can be hard to get that data to be meaningful. But that's what interoperability and standards is really all about, standardizing that data, getting it into that health IT to make sure that the data that's arriving to a provider is meaningful, it's insightful, and the provider can make decisions about a patient's healthcare based on that data that's being shared with them. So those are really important points. I also heard your points about behavioral health and SDOH, and these being places that we need to focus. And I want you to know that 100% at CMS, we are very much focused on both of those areas, and those are areas that we have targeted for future work of our interoperability efforts. So I think we're all on the same page, and that's a good starting point for this presentation. So in a moment, Ryan's going to talk to you in a little bit more detail about how data standards can support interoperable data exchange. But I wanted to start by telling you how we at CMS integrate those standards into our policies and help infuse them in the healthcare market and in industry to work with folks like you guys in the room and other folks in this industry to really advance interoperability in health IT. So if you were going to take one nugget from my part of the presentation today, I would hope that it will be that CMS and our partner agencies are really working together, and we are committed to increasing interoperability and the availability of meaningful, usable data. Again, getting back to that point of there is a lot of data in healthcare, but we want it to be meaningful and actionable for patients. So if we can jump into the next slide. What is not covered on this slide is our first interoperability rule, which some of you may be familiar with. back in 2020, CMS published a final interoperability rule that was about interoperability and patient access to health information. In that rule, we required payers to build a patient access and provider directory APIs to start making payer data available to patients and to industry to really bring payers into the fold. A lot of interoperability efforts in the past have focused very much on just the use of provider EHR systems and getting data into those systems, but we really wanted to start talking about how can payers better support interoperability, and that's what we did with Interoperability Rule 1. Again, I apologize, I don't have a specific slide for that, but this slide now focuses on our latest interoperability rule. The proposed rule was published in December of 2022, so just a few months ago. So on December 6th, we released the rule, the short title being Interoperability and Prior Authorization. And this rule really focused on the use of FHIR-based, so standardized APIs or application programming interfaces to support the process of prior authorization, which has significantly been a significant source of burden in the provider community. We are attempting through this rule to streamline that process of prior authorization and also to bring better transparency to prior authorization and make sure that all stakeholders across the healthcare system have better access to information. So the comment period on this rule closed. We received almost 900 comments. There was a lot of interest in the rule, and we are currently working on what the final policies will look like. But I'm going to tell you a little bit about the proposed policies so you have an idea, again, of how we are integrating these, the use of FHIR-based APIs and data standards like the US CDI that Ryan's going to talk about in a moment, and we're infusing them into our policies and requiring them of those that we regulate. So in this rule, this rule applies to several sets of impacted payers. That would be the Medicare Advantage plans, state and Medicaid and CHIP fee-for-service agencies, Medicaid and CHIP managed care plans, and the qualified plans on the federally facilitated exchanges. So it doesn't include the commercial market. However, with regulating this many different payers, we believe that while the payers will roll out these policies to their Medicare Advantage line of business, we're also hopeful that they'll roll it out to the commercial lines of business as well, especially understanding a lot of the efficiencies that these policies will bring. So what did we require of the payers? We required them to increase the patient access API to include prior authorization information. That API already includes claims and US CDI data, but now we're adding prior authorization data. We would require the plans to also make a provider access API available, which would allow providers to pull all of that patient data from the payer into their EHR. And again, I hear you on making that data meaningful. We want that data to be meaningful. There is a lot of information, and that's something that we need to work with the EHR developer community to say, how can you pull that data into this system and present it in a way that is most meaningful to the providers that are requesting it? So that was the second API that we would propose to require. The third API would be, again, a requirement for payers, and that would be for payers to exchange data with other payers so that the patient can bring their data with them if they're moving from one payer to another. So let's say we have somebody that is moving out of Medicaid but into the marketplace exchanges. We want to make sure they can bring their data with them to their new payer and thus continue to share it also with their provider and access it through the patient access API. So with that in mind, those are three what I call access APIs that allow access to information coming directly from the payer to either the patient, provider, or another payer. Then finally, we proposed a prior authorization API that would facilitate the process of actual electronic prior authorization. Much of prior authorization today is done manually or through portals or fax machines. This API would support electronic submission of a prior authorization request directly from a provider's EHR. So they could use this API. Again, this is a requirement on the payer to build the API, but the provider can use the API to determine whether a prior authorization is even necessary for a particular item or service, to determine what documentation needs to be submitted if the prior authorization is in fact needed, and then to actually submit that prior authorization electronically. So really streamlining that process of prior authorization, all using FHIR-based APIs. and the standards that the US CDI standards that data standard that Ryan will talk about in just a moment. In addition to these API proposals, we also propose a few guardrails for prior authorization, like limiting the time a payer has to make a decision to 72 hours for an urgent request or expedited request, and 7 days for a standard prior authorization request. We also propose to require that payers would have to include denial reasons with when they deny a prior authorization. Things intended to reduce burden in the healthcare space so that providers can put time back into their patients. So those are all the requirements that we included for payers. We also included some requirements for providers, and these requirements would apply to eligible clinicians, hospitals, and critical access hospitals that participate in the Promoting Interoperability programs. So we added a new measure in the Promoting Interoperability program that would require those providers to report on how often they are using this API for prior authorization purposes. And the idea here is by bringing providers and payers to the table and requiring them both to build these standardized APIs, we are ensuring that we're closing the loop, with both sides of the prior authorization equation coming to the table and using this API for interoperable data exchange. This is also significant because it's the first time that we've required providers and payers to conduct this sort of bi-directional data exchange, where it's not just sending data one direction and hoping that it arrives and is used. It's actually conducting a data exchange two ways and using that data exchange to make decisions about patient care. So this is a pretty significant change in our interoperability efforts at CMS. And we hope that it has a significant impact on the way that we streamline our data flow in our interoperability, I should say, interoperability and data flows in healthcare. If we go to the next slide, I'm going to do a time check because I know we are a little bit condensed today, so I'm trying not to take too much time, but we're really enthusiastic about this topic as well. So on this slide, I just wanted to emphasize, again, our commitment to interoperability. CMS is committed to interoperability. We're committed to working with ONC and our other federal partners to advancing interoperability in ways that is most meaningful to you. I heard exactly what you said when you were sharing your nuggets from this morning's meetings, and apologies that we weren't there to hear this morning's presentations, but for us, it is really important to hear those insights and that feedback so that we can determine what are the next target areas that we need to focus on. I already know about behavioral health and SDOH 100%. We are, like I said, focusing in those areas to see what we can do, but I know there are also other opportunities out there, and so CMS will continue to identify those opportunities and find ways to integrate these standards, and either through regulation or other means, make sure that we are advancing interoperability, again, in partnership with our federal partners. To do that, we will continue developing at least a final rule coming out of this proposed rule, and probably some additional interoperability regulations coming out of CMS in the coming years. We're going to continue to support expanding public health infrastructure by working with ONC and CDC on opportunities and places where CMS may have levers to make advances in that space. We also support innovation, and I combine that with the next box here on the slide of refining implementation guides. CMS actually provides in-kind support to FHIR accelerators, those standards organizations that help to build out the standards that will support our policies. So we provide in-kind support, we participate in work group meetings, and we help to advise where CMS might be going with our interoperability direction to make sure that industry continues to evolve their standards and their implementation guides to support that policy, or we are also working to adjust our policies to support where industry is going with those guides. So it's a two-way street here. We want to make sure that we are working with everyone in industry to meet the needs that currently exist and to follow the future path that industry is developing. And finally, on here, I have leading by example, because in addition to CMS being a regulator and putting out regulations about interoperability, we are also a payer ourselves, and we also facilitate a lot of different quality programs for providers. We have our own Medicare fee-for-service business and our own, of course, internal operations. And we like to think that we are leading by example because we are using these standards and the same technology to build out the tech that we use in our programs, not just through the regulations, but also through our own operations and our own Medicare fee-for-service business. And so you will see us building out these APIs that I just talked about that are required for payers. We will build them for Medicare fee-for-service, and we hope to lead the way and set a best practice example for other payers in industry. So I'm going to pause there and pass it to Ryan to talk some more about USCDI and the other work that ONC is doing, and then I will be back for questions. Thank you.
Thanks, Alex. You can go to the next slide. Oh, sorry, there's a build. Okay, so USCDI, there's also an extensive amount of information on our website, which we can get out to everybody. The ONC website, Alex is very familiar with our work. We're very close partners, and we would not be able to do anything that we do at ONC without the coordination and collaboration that and the partnership we have with CMS. So just to say that, given the theme and the topic of your sessions and why you are all there and all the work that you're doing together, if we do not have transparent, really close collaboration, then it's not possible for really healthcare as it currently exists and kind of leveraging modern technology. It just isn't possible at all. So just to make sure that everyone remembers that, and it is a tremendous burden on the providers, the payers, on really anyone that you're getting funding from, to have redundancy and duplication of effort. That's why we created the US CDI program to begin with, and why we've created US CDI Plus, which I'm going to talk about in a few minutes, because we just learned that there is a new agreement or relationship that has been made official this week, officially official, with CRISP Shared Services, who we work very closely with at both CMS and ONC and CDC. They're one of our most trusted partners in terms of how we make sure that we are verifying any recommendations that we make and that we can move the data, whether it is via a FHIR payload using an application programming interface or API, or as we're talking about here, in establishing really well thought out specifications and recommendations, because in some cases it's not a regulation and it's not a requirement, but it's a suggested approach that we have vetted throughout the ecosystem. So that's really exciting that partnership is now official. The US CDI process I'll just come back to, and then I'm going to have to cut to the chase because I unfortunately have a hard stop this afternoon. But we have an open, transparent, collaborative process with everyone in the US. So if you're not familiar with and you haven't ever had the opportunity before now, whether you live, no matter where you live, frankly, or kind of your perspective or background, that anyone can provide submission and comment using our platform. And the same will be true for our US CDI Plus program. So United States Core Data for Interoperability is now in its 4th versioning. And this is part of our current regulations and then maps back to, as Alex noted, CMS requirements. So again, you can go and find a lot of information here. You will start to see us sprinkling in things like date of initial onset, which is really important to public health, things like location, facility identifier information, which is important, for surveillance purposes, but also for administrative and payment reasons, and social determinants of health, and how that is going to extend out into other areas, for example, behavioral health. That's all coming soon from ONC and our federal partners across HHS. So we can go to the next slide. And I think that these are going to get shared out, so I'm not going to spend a lot of time here, as I noted, but you'll see this is very meant to be ubiquitous in the sense that anyone can use it. It doesn't matter. The format doesn't matter. There's a lot of technical specifications that, again, I know a lot of people in the audience might not be informaticists per se, so we don't need to spend a ton of time here. But when you look across, your partnerships and the places that you collaborate, I think you'll see that USCDI is starting to translate and transcend into some of the areas of differences in that way for your community of healthcare practitioners, whether you're in the hospital setting or not. This is really meant to make sure that your technical specifications across those systems are consistent, and that allows you, when you need to make decisions about whether it's patient care or for the population health at large, you can do so without having, a really messy data quality issue to clean up, which is what we've heard about consistently. We hear about it all the time. It's a headache for everybody. Go to the next slide if you don't mind, please. And that's really how we came up with USCDI Plus. So that USCDI core, as we like to refer to it, is required or strongly recommended at this point. So version 4 is not yet required, version 1 is, and it has had to be adopted by any user of certified health information technology. So that, I think, I don't know all the vendors that are in the room right now, but you're supposed to be able to make sure your providers and your customers know how to use your systems in such a way that they can get all of that information in the set of requirements, and they can all know how to get that, and then that it's available downstream as well. So USCDI Plus is much more specific and narrow. So right now we have live, in conjunction, and just to demonstrate further the partnership with CMS, an initial set of data elements and recommendations tied to digital quality measures and the future of the use of FHIR for CMS purposes. So you're going to see more coming out from us jointly, and that is live on the ECQI Resource Center now, and also out for public comment. We have a new platform being built that will start to, and I'm pointing, realizing I'm not in person, but if I were in person, I would point to you to look for quality and public health. We have a new platform going live. You'll start to see sprinkling in of the health equity discussion, like Alex also mentioned, and increasingly behind the scenes, we're working with our partners at NIH, NCI, ARPA-H, and new agency, FDA, and others to make sure that research and real world data for evidence generation, that all of those areas are being captured. And as I said, behavioral health is also coming soon. Next slide. This just represents all the different partners that we work with. And then I'm just going to ask you to skip to the second to last slide about public health, just for purposes of this conversation. And then I'll kick it back to Alex and open it up for everyone in the audience to ask questions when I have to jump off. But so for public health purposes, we've been working very closely with CDC for, it's been, I guess it'll be 2 years this coming fall in October, but we took advantage, we found a silver lining from the pandemic and said, okay, we know now with certainty that there is a problem, that public health and clinicians, that we are not moving data effectively across the different systems, in not all instances, going back to the CRISP example, where there is a very well-established stack, a technical stack, and the infrastructure in place that's we know is scalable, but that's not possible across the 3,000 plus local public health offices. That's not a precise number, but it's approximately that much when you think about all the different state, local, tribal, the territories in your example, all the different jurisdictions. Like, we just have to do this better. We had some early testing where we were trying to determine what are the most important data needs from vaccine availability perspective, and also how we can best find the most at-risk populations. And so we had enough information and knew where some of the best practices were and some of the opportunities were. And then we extended that out across the entire organization at CDC. So we have hundreds and hundreds of team members that have been participating in this process. And we came through and specified what our top 7 were. And now we are really excited and proud to say that we have initial preliminary sets of recommendations in each of these areas. And as I said, this will be publicly made available in hopefully a month or two, less than maybe 4 to 6 weeks. I'm hoping that we have good news to report back to you. And why this matters is important is because we are going to be working with you in the Virgin Islands to make sure that your interests and needs, especially from the laboratory data and the maternal and child health perspectives, that we know, what's working and what's not. And we also understand from a federal perspective, the challenges from an implementation point of view with building out a truly interoperable health system that takes advantage of the best of that, health IT has to offer, but also, doesn't underestimate the challenges, the unique set of circumstances and challenges that you have in your communities. Because I personally have a background in working with coastal regions and island nations from an environmental and economic development perspective. So I, happen to really appreciate that there is not always a one-size-fits-all solution. But on the flip side, from the kind of like user experience perspective, but we do know that from a technical exchange perspective, there are only so many ways that really work efficiently and effectively and securely and accurately to move information. So balancing those two things where we can say with confidence, this is the best way to do this technically, and then be able to tailor it to the unique set of needs that you in particular might have. So with that, I will stop and turn it back to Alex for any final comments. And if there are any questions from the audience later, I'm happy to take those offline, and really just commend all of you for making time to be there together and to work together on this important matter. Thanks.
Are there any questions that we can help to answer?
Thank you, Alex. We'll see if there are any questions. I think we've got a lot of stunned looks. I think someone had asked everyone to say interoperability 5 times, so that's the first challenge, just saying it. Then comprehending comprehending all the rules of the road around it. Let's see. I don't know why I'm up there. I'm already up here. I think this is an edition of Punk'd.
We are
Yes.
always happy to answer questions.
Oh, here we go. Sorry, we had a little interruption. Can you hear us, Alex?
Yes, I can. There's
Sorry,
a little
we had an
delay.
interruption. We do have a question.
Sorry, do they have a microphone?
Yep, they're bringing a mic.
Great, thank you.
Hey, Alex, this is Karen Shields. I have a question. So, as I was sitting here in the audience and listening to both of you speak, I thought about how there's a bunch of us here in the audience, and some of us are uninitiated with what USCDI even is. But let's just say at the basic, it's just that's okay. It's an opportunity for to basically regulate some standardization so the communication happens across multiple things, multiple platforms, to make it easier for folks to share data. Do you know of, and I think you guys already started talking about some things that you're working on the USVI with. Are there grants or any funding opportunities for the USVI to actually initiate pilots and proof of concepts for the population that they have here? And even, especially if we can talk about being able to measure or quantify outcomes, right, that are a result of a small population having some, some sound interoperability happening, and even with a risk stratified population, right? So something that actually creates a business case for a national implementation of something that could happen and allow you to maybe, have something written to help with your future regulations, right? So quite simply, funding for an opportunity for proof of concepts to happen here in the USVI with a small population to prove out how that actually, when it does work, people actually do get better?
Yeah, that is a great question, and I would have to look into. I don't know of any funding opportunities, at least not on the CMS side. I do believe that ONC they have different funding opportunities. I don't know if one would be applicable here, but that's a question that I'm happy to take back.
Test. Any other questions? Alex, I think we don't have any other questions, but I know that Ryan's not on still, but I do want to acknowledge this while you're on, that Ryan Argentieri has been incredible and incredibly accessible in answering my questions, which are plenty. So I know that you guys have many. I don't feel like I have the option to be shy about them, but when I've said, Ryan, I've got questions and we have needs and I'm not sure even how to articulate it. She's even met with me at a cafe in DC on a Sunday. And so that for me is a great experience of working with federal partners when sometimes the perception is that you are very inaccessible. So thank you for being accessible, even in sharing your pet communicating as well with us. And I only highlight that. I don't want you to feel embarrassed. I have 2 little boys that are here with me today. So thank you again for your time, for sharing. We do want your presentations, please. We have your presentations, but any other information, as Karen Shields mentioned, if you've got kind of a 101 on USCDI Plus, please send that to us and we'll distribute that. But thank you very much for your time and for sharing.
Absolutely, thank you. There are some excellent resources on ONC's website as well if you want to access the USCDI information there, but we do have this presentation. I think the last slide might have our contact information on it as well, and we will be effective. So thank you.
Thank you. Okay, so we're going to get ready for our next group, which I think will be very interesting. We're veering off the beaten path a little bit with a panel. So all those panelists, I'm asking you to come get on the stage so we can get ready. And as they do that, I want to highlight a few people, a few friends that I've seen, and highlight a few other things, and a few partners we have. I don't know that they're in the room right now, but PCG has been with us for about 2 years, or a year, I suppose. Public Consulting Group. As our project management office, as we're navigating towards the HIE. So I don't know, I don't see Andrew or Michael in the room, but I want to say hi. There's Andrew at the back. Thank you guys for being here. Please feel free to talk to them about kind of where we've gotten in our process. Raul, if you could please stand up. Raul Alicia, out of CMS out of Puerto Rico. We love having our friends from Puerto Rico right down the road here with us. Thank you, many of you, for being here. Also, Point Click Care. I know you're kind of on the other side of the veil, but I wanted to recognize Lauren and Tom. They've also kind of been here in the territory with us for a little while. They implemented Pulse, our ability to track patients in and during storms. And they've got a booth on the other side. So feel free to connect with them. Thank you for being here. I think we're missing a few folks. Do I need to call some folks by name? Okay. Let's see. I'm going to be calling some folks by name to come join us. Alexandra Francis. I believe you are on this panel. I was just about to call my good friend, Director Ross. Do we have Conrad Clyburn? Yeah, there you go. Brandon? I'm just wondering if you wanted me to give a red carpet entrance here. Greg Bryant? Dr. Bacot? Naira Stout? We've got Brandon Lewis here. And Sean Weideberg. So again, seeing as how large this panel is, I'm going to ask you, and Greg, you can just grab a lap. You can sit on someone's lap. Maybe Brandon Richardson's. That will just make it interesting. We'll wake everyone up. Speaking of waking up, I have totally neglected to let you know that there is a cafe upstairs. There is an upstairs. If you peek through behind this veil, you'll see a stained glass window. There's a cafe with like real espresso. So if you need espresso, head through my right, your left. Find the stairwell that will be to the right. They've got smoothies, they've got espresso drinks, they can make them really fancy with almond milk and regular milk and other milks. So if they start putting you to sleep, you can feel free to take a break and go upstairs. But I think this panel is really important. I invite any of our sponsors, our vendors, exhibitors to come and listen in, because this is your opportunity to, we don't do fireside chats. We don't need additional fire down here. So we would call it like, we gonna sip some local juice, we gonna drink a Heineken. That's what, especially what the men do. They drink a greenie and chat. So I'm not providing the beer. I'm not, oh, I am so sorry. And that would be my phone ringing. No, sorry, I'm not providing the beer right now. We'll just pretend that you have one, and let's have a chat. You're gonna hear from a variety of perspectives, businesses locally, and also you're going to get to hear from a state that we've partnered with, West Virginia, through the Medicaid program. Director Gary Smith, I don't know if he's in here, but he's been working hard to refoster that relationship that was started actually years ago with West Virginia for leverage and reuse purposes, not in reinventing the wheel, learning from a partner, being able to utilize their resources. But you're going to hear from our hospitals. You're going to hear just a variety of perspectives in healthcare, in IT, business, as to what are the challenges as we talk about modernizing and transforming and making systems interoperable. It's easy to throw these things out, but it's like, okay, what does that really look like? And what are the challenges and barriers, or what are the opportunities? So without further ado, I'm going to ask Conrad Clyburn to take over. He's also going to introduce himself. He was here last year with us participating, and I welcome you back again. Thank you.
Pleasure to be here. Thank you. Oh, okay. Thank you. I'm Conrad Clyburn, the business advisor for development at Zane Networks. Dr. Sandra Ford this morning emphasized the importance of equality versus equity. Governor Bryan talked about the importance of connectivity within the Virgin Islands, and that he had the objective of being the digital governor as part of his legacy. The Virgin Islands offers an incredible environment with an HIE pilot that's just starting out with the Virgin Islands Next Generation Network with Dow Wade and his people, bringing in broadband. With the Vivis program, that was Vivis program that was briefed by the Chief of Staff this morning, incredible. And that might be unique and novel as far as the infrastructure for longitudinal tracking of information. Not only medical information, but social services. We have the University of Virgin Islands just opening up an innovation center. Got a simulation center in the medical space in St. Croix. And I was particularly impressed with the economic development and the 70% federal tax incentive. You know, so there's a lot going on, and we have a panel here of individuals that can kind of talk about what the opportunities and challenges are, where the rubber meets the road, where the real work takes place. And in the interest of time, I'm going to ask each of the discussants to do a short introduction of themselves and what they see as the real opportunities and challenges in their domain. And then we'll open it up to the audience for additional clarifying questions that will be sparked by your initial comments. And just to be fair, we're going to go from my left to right. So everyone's of equal importance. And if we may, we'll start to the far left with an introduction. And then what do you think are the biggest challenges and opportunities here in the Virgin Islands as it relates to everything we've heard up to this point?
Good afternoon. I'd like to introduce myself. My name is Rupert Ross. I'm the director for and where the rubber meets the road for the governor's digital transformation, the director for the Bureau of Information Technology for the government of the Virgin Islands. My role is I take the vision of the governor and I try to execute on that to digitally transform the government of the Virgin Islands to provide better services to the people of the Virgin Islands and the visitors of the Virgin Islands. Very quickly, I see that we have a lot of challenges in the Virgin Islands. We also have a lot of opportunities. Some of those challenges are related to having the right expertise at the right time to be able to execute on the vision of the Virgin Islands government and the governor of the Virgin Islands, and to be able to fund that opportunity. That was an awesome picture, Dr. Ford. Being able to show equity and to be able to understand that we're here in the Virgin Islands and not necessarily every funding opportunity that we get from the federal government puts us on the same level as everyone else. Funding the long-term opportunities to transform the government of the Virgin Islands is one of our biggest challenges. And I would stop there, and I realize that this is a large group, so I'm not going to hog that discussion.
Oh, but thank you very much. And the importance of funding and having visibility on what funding might be a good intersect with everything that you're doing here is something that, I think as a collective we can all work on. Please, next.
Good afternoon, everyone. I'm Alexandra Francis Smith from Virgin Islands Next Generation Network, and we are, of course, the middle mile service provider for the territory. We are a semi-autonomous government agency, and our opportunities as it relates to the territory and in support of OHIT and all the panelists here is our federal grants and the opportunities that we via NGN support. Unfortunately, Daryl had to step away, so I'm here in his stead. Thank you.
Well, let me just add to that. I was at a meeting last Thursday at the White House on Broadband for All initiative coming out of the administration, and a big piece of that was health equity. And
Yes.
One of the big challenges that kept coming up was what Dr. Ford talked about this morning, which was getting those resources to community-based organizations, as far as operating funds, indirects, et cetera. So that's something that, again, as a collective, that we could probably work on. And I think it was Dr. Awanda said that you can go fast alone, but you can go far together. So, hopefully we can go there together. Brandon?
Good afternoon, everyone. My name is Brandon Richardson. I'm the Vice President of Information Systems here at Snyder Regional Medical Center. In terms of our opportunities, I think we're here at a great time at Snyder. We're in the middle of our implementation of our new EMR. This solution will give us the foundation for us to leverage a lot of the new technologies that are coming out, telemedicine, AI, which is very big in the market today. And I think with the right funding and the knowledge base, and I'm sure you can probably hear this throughout the rest of the panel, funding and the knowledge base, we would be able to really bring the Caribbean, not only the Virgin Islands, to the next level and ride that wave, as Michelle said.
You mentioned AI, and tomorrow there's a panel on artificial intelligence, and Dr. Washington from Howard University, one of the top experts in AI and healthcare and health equity. Yeah, she'll be speaking tomorrow. So, and Howard and the University of Virgin Islands are partnering on some other projects together. So,
and I'm a fellow Bison as well.
Oh, I'm not. So, no.
We'll forgive you.
Okay. Next, please.
Good afternoon, everybody. I'm Greg Bryant. I'm the CIO at Governor Juan F. Louis Hospital in St. Croix, and I am basically the Brandon for St. Croix. So we're doing the Meditech Expanse as well. I think I will speak on my vision and goal is to break down the walls of a hospital and bring the care to the doorstep through technology like telehealth and FHIR. I am looking at trying to do a hospital at home setup where if the patient is acute and at home, we bring the care to them. Culturally speaking, my time being down here, a lot of people don't want to go to the hospital. And I can completely understand hospitals aren't the most pleasant places. Though we got a new one open. But I want to bring that to them so that way they can get the comfort they need, but at the same time, we are taking care of our community like we should be as being stewards of a hospital. The care team is everybody. It's me, it's Brandon, it's somebody working in dietary, it's somebody working in facilities, it's everyone involved. So we're trying to collaborate the best we can to get the patient back on their feet as fast as possible.
Thank you. And now at St. Croix, you have the simulation center down there as well.
The
Is
RT
that part?
Park, yeah, the RT Park, yes.
The RT
There's a
Park?
simulation. It opened a year and a half ago. But yeah, it's at RT Park at the University of Virginia.
And I understand that's a state-of-the-art simulation center.
It is one of the best in the country, yes.
Right. Okay, great. Next, please.
Good afternoon, everyone.
I think you might need to switch.
Good afternoon. I'm Brian Bacot. I am a physician here, orthopedic surgeon specifically, and I am the owner and originator of Comprehensive Orthopedics, which is more locally known as COG, and its collaboration of family of services, which include orthopedics, surgical centers, rehab. We also have a GI component to it with this surgical center and that component as well. And I service the Virgin Islands, Tortola, Anguilla, and I am also president of the Medical Society. I'm president-elect, past president, and I am also a board member of the medical board here as well. And my job here is to kind of really be where the rubber hits the road. We are not only representing the healthcare community, the providers. Locally, we're not only the rubber, we're also the tread. So you have to be careful with us. You guys are servicing us. You may be the car, and we know it. You're the car, you're the generator, and the engine is always thought to be the most important portion of it. But if we take the wheels off that car, it goes nowhere. So just make sure that we stay focused on that. And that's my job, to kind of keep everybody focused on where we are. And I kind of think of all of this healthcare, IT, and everything we do in healthcare as kind of this, that story that's analogous to the elephant. And you have 5 wise men who are blind being led to the elephant and told, please describe this elephant. One goes to the trunk, one goes to the leg, one goes to the belly, one's to the ear, and one's to the tail. And you can imagine the 5 different descriptions of what we're talking about. So when we're talking about health IT, and we're talking about the information exchange from a provider standpoint, you really have to, from a national standpoint, talk about where we're going. What vision are we trying to achieve? And then look back at your providers and say, how do we get there? How can we facilitate? You guys are in the middle. You're building this behemoth for us. You're building this structure, and it's all focused around the patient. But where that rubber hits the road, we need to be able to understand how we can help and articulate how it's best that we get that information and that guide. And along that route, and everyone always talks about how busy their doctor is, and I'm a surgeon, so I walk in and people are like, oh, I know you're busy, you're taking your time out, oh, you got a day off. We are busy, but we're invested in our patients, we're interested in our patients, and so the portions that are important for the physician is, one, being educated on where we're going in that vision, and we need carrots, not sticks, to get us there. And we also need the funding. And when we talk about equity versus equality, we're not a state, we're a territory. But when we have the highest cost per electricity in any of those Welcome to the Virgin Islands. This is so when we're looking at equity versus equality, we have to look at those dollar cost amounts. What does it cost your provider to be able to implement these things? And so we need state, local, and federal dollars to help the providers educate themselves and then be able to implement these carrots that are being presented in front of us.
And just in response, Dr. Ford talked about the documentation, the guidance that's coming out of the White House in regards to grant reform. So that, and then, like I said, I was in a meeting just last week at the White House, the same, and it may have even have come from Dr. Ford's studies and so forth, that they know that there's a problem, that the money needs to get down to where the rubber meets the road, down to the community-based organizations, and there needs to be reform in that regard. So I associate myself with your comments completely. Next.
Good afternoon. My name is Brandon Lewis. I'm the director for the West Virginia Office of Medicaid and CHIP Enterprise Systems. My office oversees the implementation and operations for all IT systems that impact the Medicaid enterprise. Currently, we are modernizing, and I put that in quotes because I feel like we've been modern for some time. We've had a lot of innovation that's happened in West Virginia. And part of that innovation years ago led to a great partnership with the Virgin Islands. And the question was like opportunities for the VI. And honestly, just keeping this partnership going forward. I want to, the governor's, he wants to be known as a digital governor. Well, I want to help him be that digital governor, and I think West Virginia can do that. We are slowly rolling in a new modern MES. We're looking at our current existing legacy Medicaid management information system. And instead of just saying we're going to just start over, we want to look at it, what is needed to be upgraded, enhanced to move forward. And everything from MMIS all the way to eligibility and enrollment. We're getting ready to implement a new IAS, integrated eligibility system. We just recently implemented a new enterprise data solution, which is a data warehouse solution for West Virginia. So I say all of that because whatever the VI would need, whatever assistance that Gary and his team need, West Virginia wants to be there for you all. One thing we've done recently, just to kind of highlight, and we'll probably get into this into a session later, is we've started peer-to-peer conversations with the Medicaid team on site here and my staff in West Virginia. And it truly is a lesson learned both ways. We're learning from you all, you're learning from us. So again, the biggest opportunity I see for the Virgin Islands is continuing Michelle had mentioned that with Gary's fostering this partnership because it's been around for a long time. We want to establish a new MOU because it's been around a while, and it's time to reestablish that and get that conversation moving. Because again, wanting the USVI Medicaid team to be a part of our conversations going forward as we modernize our systems, to me, that's a good opportunity for both sides, not just USVI, also West Virginia.
All right, well, thank you. And I think it's important thinking in terms of bidirectional best practices, and as new practices may emerge in the ecosystem in the VI or in West Virginia, those can be validated in a different environment in each case, and maybe scale, nationwide. So next up.
How's everyone doing? My name is Sean Wiedeberg. I'm the COO of Bailey's Medical and Pharmacy. We're a little different than everything else that's been going on in this conference today. We're not IT. We're truly boots on the ground. We are a durable medical company. We started 10 years ago. We started in a little 600 square foot office. Today, we currently have 16 offices in 5 different states. So we know how to open up durable medical equipment offices in small rural areas and grow them to large functioning companies. Equipment's pretty important in the discharge process. It keeps patients from readmitting into the hospitals, which costs a lot of money on the health financial system, for sure. I don't see the infrastructure on the island as far as a company that you can send a patient that's going home, they need a hospital bed, a wheelchair, and a walker. I don't see a company that's gonna go in there, set them up, educate the patient on how to use the product so they're safe at home, and then go back into the hospital. So that's what we're looking into possibly starting in the Virgin Islands. I think there's a big opportunity for us here, and we're just kind of educating ourselves on the island, the people, and the community to hopefully be a part of that.
Oh, well, thank you. And not being from the Virgin Islands, I do see that the hills can be a challenge sometimes. And I would assume that that would be important in terms of mobility.
We got delivery vans. We'll get up there.
Okay, good. So let's open it up to the audience. We've got a good and very expert panel. Gary? And do we have a mic that we can bring? Yeah.
Okay, good afternoon, everyone. This question is for Dr. Bacot. So Dr. Bacot, with the, there has not been much discussion. There has been some. We're currently going through the public health emergency unwind. And, approximately 21% total Medicaid members here in the territory are going to be disenrolled. So, my question to you is, how can we, as the Medicaid program, help you as a provider be able to ensure that the members that you serve, which you serve quite a bit of our members, and thank you for that. And thank you for your continued support of the Medicaid members of the Virgin Islands. How can we help you ensure that we, empower your office to ensure that those members can continue to still obtain access to care from your team?
Thank you for the question. I think my hands must be electrical. There. Thank you for the question. One of my fears for the participants that we have, our patients, is that there's funding changes that are coming as we're coming off of the emergencies. First we had the hurricanes, we had 2 of them, and as soon as we're trying to creep ourselves way out of the debt and the chaos of the hurricanes, we get the pandemic. We were able to expand our access for our patients and our islanders by getting the Medicare services. And we're fearful as providers, what's going to happen to those patients as some of this funding gets withdrawn. We hope that we can maintain some of the gains that we've had in percentage balances from the national Medicaid distribution of federal dollars. Your offices now do quite well with getting communication. We have a very personal communication with your office. You're very responsive to our patients. But we want to make sure that you guys have this funding to be able to support our population. I want to say, I think when I spoke to you before, you have somewhere around 40,000 participants right now. And if you're going to lose 20-some%, what are we going to do with that clientele population? How are we going to service them? How do we manage them? That meets some challenge. But right now, communication is the best thing for us. Getting the digital system set up so that we can electronically register those patients and easily get them into the system when we find them, and be able to interact with your offices very well with this, tracking the patient as well as with billing, and then also receiving the funds that come behind the bill, so would be helpful too. So all those are the things I see right now. But we're working on that and have come light years over the 15 years I've been here.
Okay, thank you. I'm sure we have some more questions, but since I'm the moderator, I'd like to ask a question. And this is for, is it Alexandra?
Yes.
Okay. The Broadband for All initiative coming out of the administration, I understand, has a baseline $100 million, at least for every state. I'm wondering, is that also true for each territory gets a baseline of $100 million? And if so, what kind of plans do you guys have?
Under the Digital Equity Planning Grant, we were awarded, and then under B, the territory receives $1.25 million.
Okay, 1.25 million?
Correct.
Okay, not 100 million?
No.
Okay, all right. And is any of that, is there like a plan to leverage that for any kind of health equity?
That would be under the Office of Management and Budget, and also in conjunction with Virgin Islands Next Generation Network. So they're pretty much going to develop that program.
Okay, great. Going back to the audience, or is there any comment among the panel? Okay. Going back to the audience.
Well, I have a question. Okay. So did you find the funding, the 1.2 million, is that adequate for the territory? What do you think were we going to be able to produce with that money?
So the plan for digital equity as it pertains to VINGN, how we would support that is through the infrastructure, helping to develop the infrastructure to support your modernization of the healthcare industry. So whatever software or whatever the team develops under the Office of Health IT, we would then support that. And that's how VINGN supports that.
Is the funding adequate? 1.2?
I can't really speak to that. At least you have a question or a comment?
I don't know if everybody heard that.
Was that sufficient funding to support the program?
Good afternoon, everyone. My name is Elisa Hodge, and I work at VINGN with Alexandra. Is it me, or does the microphone sound a little croaky?
No, we can hear
I'm
you.
fine? Okay, great. Yes, I just wanted to clarify that the $1.2 million that OMB was awarded for the BEAD program was just to plan what they would like to do with the funds. The territory should expect to receive a minimum of $25 million. It could be more based on the formula, but at a minimum, we are guaranteed to get $25 million under the BEAD program.
Excellent.
Now, VINGN, we are going to be the digital equity department, so to speak, and we were awarded a $150,000 grant, as Alexandra explains, and we have a year to create a plan of which we could possibly get up to $8 million to be able to perpetuate digital equity in the U.S. Virgin Islands.
Excellent, excellent. Okay. Director Francis, I was just wondering, how am I doing on time? It's time to wrap up. Do we have time for one more question? We have one more question right there. If we can get the gentleman with the hand up, the mic.
Thank you. There we go. This question, and thank you for allowing me to ask one last question, is for the CIO of the Juan F. Luis Hospital. You mentioned that your organization is looking at a hospital at home program. If so, well, first of all, awesome. Second, what are your expectations of that program, and what technologies are you looking at that will allow you to meet the patient where he or she is, given constraints of internet connectivity, also access or digital literacy for that matter? I'm just looking into how we could maybe collaborate on different endeavors that allow you to service these patients regardless of their socioeconomic background, whether or not they know how to use a smartphone, whether or not they live in a geographic area that allows them to have access to high-speed internet, because there's an array of technologies in the market. It's about finding the ones that truly accommodate to your patient's realities and making sure that you're not broadening the digital divide instead of you're narrowing it so that no one gets left behind.
No, sure. Okay, good question. First of all, with any technology, you have to look at the education piece. Me and Brandon can sit here and talk technology all day and night because we understand it. The average person doesn't get what a FAP is, or doesn't get, what a stack of service, what they do. So we've got to educate the patient and the community on what we're doing first. Be it a pop-up, be it classroom sessions, whatever that looks like. From a hospital at home standpoint, it would take our case managers to educate the patient on what we're doing, and then our nurses and physicians knowing their patients well enough to know if they can handle it. If the patient cannot handle what that takes, we're not going to do it. We're not going to put any more stress on a patient who's already sick. But for those patients who have enough literacy or can be taught the literacy to where we can bring this program to them and they can feel in the comfort of their home, we're going to do it. Will we push it on them? No. Will we offer it to everybody? Yes. So there's a fine line you have to walk between being aggressive but also doing the best for your patient. And that's where, over the next, say, 12 to 18 months, we've got to examine.
Thank you.
Well, we've had an excellent, I think, panel. We've had the director of the Bureau of Information Technology. We've had Next Generation Networking. We've had both hospitals represented. We've had the president of the Medical Society. We've had the West Virginia partnering. And you have the DME company. Okay, so let's thank the panel and appreciate it.
All right, thank you again. So now you've, if you didn't have opportunity to ask your questions, you know who to find to ask further questions to. I think I would have a lot of questions of VINGN and understanding more about that middle mile infrastructure and also the grants that are available. I'm going to just ask for the Medicaid Spotlight team to go ahead and get situated on the stage right now, please. And in the meantime, we have a video. One of our panelists was with Bailey's Medical Equipment. They've got an interest in understanding the needs of the Virgin Islands and how long it takes to get medical equipment into the Virgin Islands, and an interest in working with our provider community. Their CEO was unable to come, but she's going to provide greetings as they get on the stage. So you guys can feel free to roll the video clip. And again, a reminder that you can get espresso. I'm also going to highlight, while we get the sound situated, that Southeastern Regional Telehealth Center has materials, as does Schneider Regional Medical Center, on the table at the front where you registered. Also, is Kim Tolliver in the room? So Kim Tolliver is a well-respected, runs a well-respected revenue cycle organization in the U.S. We also have someone locally who does as well here attending. But Kim's got a book that she's going to highlight. And I also want to mention, we talked about grants, and we talked about, Dr. Ford talked about, and as did I think Dr. Awanda, the need to be able to demonstrate to the feds what you've been able to accomplish with, you need to be able to report, and report well. Adam, I see you at the back. Adam's going to be sharing, I think it might be tomorrow, but Adam's company, Clear Impact, is a solution that is used around the world for being able to demonstrate value in a number of ways, but also to be able to track performance and measure it. So you can wave so everyone can see who you are. And I think Kim just walked back into the room. So make sure you meet her, because outside of some of the things we're talking about around interoperability and data, there's a need to make sure you're capturing your revenue. There's a need to make sure you're capturing how productive you are, or finding out ways to be more productive. So do we need to just go ahead and move to our panel, or are you ready to roll? Ready to roll? Okay.
Good day. My name is Dr. Trish Bailey. I am the CEO and founder of Bailey's franchise, which consists of Bailey's Medical Supplies, Bailey's Pharmacy, Bailey's Scrubs, and Bailey's Real Estate Development. In 2010, I was in a coma in California. While I was transitioning from California to Florida, I was wheelchair bound, my larynx clipped, so I was not able to speak. When I got to Atlanta, the flight attendant escorted me off the aircraft, placed me in a corner for my connecting flight. For 2 hours, I sat there and I cried and tried to find someone to help me to get to my next destination. After 2 hours, a young girl came and helped me. And during that moment, I realized that the disabled was invisible to the world. And because of that, I started Bailey's Medical Equipment and Supplies, because I wanted no one else in the world to ever feel the way that I did. As a young girl sits there in a wheelchair crying, desperately needing help, needing someone to care, needing someone to assist me. So that's my motivation to start Bailey's Medical Equipment and Supplies. My vision as I started the company, I wanted to expand throughout the United States. I wanted to touch each and every life who needed assistance to walk, to talk, respiratory, ambulation. I wanted to make sure that wherever I am in the world and in the country, is that the people who are in need feel the effects of what Bailey's bring. The level of service that we carry, the level of service that we offer is exceptional. It is second to none. Why? Because we care. At Bailey's, our model is simple: service, service, and service some more. Treat each person as if they were yourself. Treat each person with a level of kindness and love that they have never felt before, so that you can continue to inject positive energy into the world and into the universe. My patients, my loved ones, everything inside of my heart and everything inside my being is committed to helping them, to caring for them in every aspect of my life and every employee at Bailey's lives. Expanding to U.S. Virgin Islands is one of the greatest joy that I can ever imagine, because it means that my Caribbean people will be touched by the most amazing company that services their patients with the love and kindness that they deserve. And I am looking forward to one day meeting each of you, to be able to have a footprint on the island, to be able to touch each person who's disabled, and each person who is in need of the services that we provide. I am so looking forward to meeting each of you and being able to be in your space. Thank you.
Bailey's team, if you guys just want to stand up and wave so everyone sees who you are and can connect with you guys while you're here. So I think we've got everyone on stage, but they're about to resituate you. And Nicole, you're going to kick us off? Yeah. Okay. Nicole Becknell of Barry Dunn is going to kick this panel off. And so I leave you in her capable hands. It seems like you guys just want to take up the whole stage,
Yeah,
which
you
is
guys wanna
fine. No, however you guys want to do this. Maybe they had the oxtail that had lots of onions and garlic, and so they're keeping space.
Thank you. Are you guys going to stay? Well, it's good. Get cozy. You cozy?
1, 2. Yeah,
Everybody's going to stay. Everybody good.
But Gary can't see this far. Can you, Gary? You can't see this far, right? Okay. I'm just checking. I'm the one in the yellow, just in case you forget. And okay.
Well, I'm going to have a good time moderating today. Good afternoon, everyone. Thank you so much for having us. As always, I think this is I was counting, I think it's my 4th or 5th trip here. Every time I land at the airport, I take a deep breath and feel like I'm home. So thank you so much for always welcoming me and anyone who's with me and anyone around. It's such a welcoming, lovely place to visit and to be. So thank you so much. My name is Nicole Becknell. I am a principal with Barry Dunn. It's a consulting firm out of Portland, Maine. However, we have an office in Charleston, West Virginia, and I am responsible for the oversight of the projects that we support our West Virginia client with, and that Mr. Brandon Lewis over here that you've already met. That's how I fit into this puzzle. You'll find out a little bit more as we talk about the West Virginia and the USVI partnership. By a show of hands, does anybody know or have heard of the West Virginia USVI partnership, Leverage and Reuse? Excellent, excellent. So hopefully by the end of this discussion, the rest of you will be just as informed and have other ideas that you can use to help leverage that partnership. It's been extremely beneficial. It's been a long-standing partnership and mutually beneficial to all. So this panel is not about me. It is about our excellent panelists. So I'm going to go ahead and just have them introduce themselves, who they are. I know, Mr. Smith, we know who you are by our previous conversation this morning, because you are tenacious when you talk about the island. So if you would not mind, we would start with you. Go ahead and introduce yourself.
Good afternoon again, everyone. Welcome to the afternoon session. Gary Smith, Medicaid Director for the Virgin Islands Medicaid Program.
Again, Brandon Lewis, Director for the Office of Medicaid and CHIP Enterprise Systems for West Virginia.
Karen Shields, Chief Client Engagement Officer for Gainwell Technologies, formerly of the Centers for Medicare and Medicaid Services.
Kimberly Causey Gomez, Commissioner, Virgin Islands Department of Human Services.
Thank you so much. Okay, so without further, and I don't know if we have the slides. If not, that's okay. We can go ahead and wing it. So first of all, the first question, and I asked who has heard of the partnership. Can anyone, and I'll look to you, either Brandon or Gary, because I think you've been in the partnership the most or have the most knowledge about it. What exactly is the West Virginia USVI Leverage and Reuse Partnership?
So for me, and Brandon touched on it, you know, in the session prior to this, for me, it provides the opportunity for our team to be able to leverage best practices, lessons learned. He mentioned the 2 site visits earlier this year. I mean, they meant so much to the team. You know, we served, just as yesterday morning, 40,008 members. I did not have an opportunity to look at the numbers this morning, but yesterday morning we hit the 40,000 mark. And we are very limited with staff. So the staff, tends to be burnt out. And trust me, they work very, very hard. And I am very, very hard on them. So the trip, just provided a new type of motivation for them. And, I can't speak to it like they would be able to. And I don't know if they're in the audience, but, Ms. Carla Huggins, our claims supervisor, and Ms. Dahlia Richardson, our provider enrollment lead, they participated in those site visits. And if you have the opportunity, please don't hesitate to have a conversation with them so they can share, their experience. And on another level, regarding the reuse of technology, it saves us dollars. For example, the implementation of the, and keep me correct on this, Brandon, the implementation for the West Virginia system was $28 million. We paid 50% of that because we leveraged the technology that was already designed and developed for West Virginia. And it ever since it's been going. So when we have a CR or change request, because it's already been designed, developed for West Virginia, my cost is mitigated because of that, and that's a big plus for us because of the challenges that we have when it comes to funding.
Yes, I'll make a couple of comments to that. First of which, if you're talking about the MMIS contract itself, it was $298 million. I wish it would have been $20 million. But back to the visits, and first, I'm very happy that I got to visit this time around. Didn't think it would come true, but it did. And I do think it needs to be a bi-directional partnership, right? They came to West Virginia, now I come here. But I was able to sit in the room when his team and my team were talking back and forth, and they were going through provider enrollment, and they were going through claims processing, and it was kind of like you saw motivation on both sides. Like his staff was increasingly getting motivated and excited, and I saw a spark in my team as well, which is awesome, because again, you work day in and day out in the same processes. You're dealing with the same issues, but yet you just get together and talk through some things that, hey, the VI has some of the same problems West Virginia has and vice versa. Then it really does truly mean that we're a partnership. And like I said before, I hope we continue that.
Thank you. Karen, I hope you don't mind, I put you on the spot maybe a little bit from a CMS perspective. Like, why is leverage and reuse so important? And, CMS does require that and have that in certain conditions. Can you talk a little bit about that and how that came about?
Absolutely can. The concept of leverage and reuse was born out of a brainstorming problem-solving session at the federal level with the Federal Office of Management and Budget to try to come up with ways to leverage the investment that the federal government makes with the 90/10 funding in Medicaid systems. And so I need to tell you that in my current role at Gainwell, one of the things that I do is I go to states and I visit the Medicaid leadership there. And I've been to 16 states since August of last year, and each one of them really is a different country. It really is. Each state is like a different country. In a good way, though, right? We definitely have a diverse personality within this nation, and the USVI is no different. But the one thing that binds us together is the need to pay claims timely, well, have good relationships with providers, enroll people accurately, have a good, strong program integrity system, and that's national. Like, we want to do well by all the people who live here and who need these programs. And so leverage and reuse is an opportunity to cinch where we are alike, right? And the concept is not just a systems financial thing. It really is having more than one entity have a conversation about what is alike about you that you could share so that you could build a stronger team together to deliver services. If there were a national program at CMS and they wanted to further expand, the different states and territories that take advantage of the concept of leverage and reuse, there would be a lot more money within the Medicaid program to use to cover people, develop technology, and do good things. I'm not exaggerating when I say the more unique we insist on being, the more expensive it is.
Thank you so much. Commissioner, can you talk a little bit about where you come in? The partnership has been going on for quite some time, and we'll talk a little bit about that. Where did you come into it, and what have you experienced? What has been your experience with the partnership?
Well, specifically, good afternoon, everyone. Y'all awake? Y'all good? Everybody good? Okay. Rupert, you're good, right? Just make sure. So partnerships for us is, since day one in 2019, I felt like public-private partnership was really important, but also the boutique portion of it. Sometimes when we get into partnerships, it's so large, and then the Virgin Islands kind of gets lost in that. In the territory, because even compared to Puerto Rico has 1 million Medicaid members, and then Gary was saying that we have 40,000, but each one is just as important, as I say. And the country, when you're looking at it from like different country perspective, it's the diversity that we need. So taking what the partnership for us is when we came on board is taking the expertise from another agency or another place and saying, hey, what can we do better? And it also allows for an outer perspective looking in. So sometimes when you're doing day to day, you forget what you're doing. It's not that you forget what you're doing, but it's almost like you need another perspective, and having that external perspective. So since day one, it's been open, honest, it's been critical in some instances, meaning that, you're really not doing this well, but maybe you could do this better. So that open and honesty and transparency, I think for me as a new commissioner coming in 2019 was amazing. And having a couple of people new on our team, that 1 week of, hey, you can go to a Medicaid conference, but if you go to West Virginia for a week, you're going to know everything that you need to know. And so it was really week number 2. And so for us and for our team, I think it was a pretty amazing experience.
Great. Thank you so much. I'm going to take us a little back in time, and can anybody talk to how it all started with the governors at the time in West Virginia and the USVI? And some of it I know may be a little bit.
Yeah, I'll try here, right?
Okay.
So this does predate me a little bit. I've been with the department since 2004. Only been in the Medicaid space now for 5 years. But my understanding is that 2 governors, a governor from West Virginia and governor from the VI, had a conversation. I think it fell on the CMS looking at what the needs were, trying to get entities understanding that there is 90/10 funding out there, and then what truly made sense for a territory such as the Virgin Islands and what they needed and what truly could become a good partnership. And my understanding is that led to an MOU that was signed that then led to the ability for the VI to be able and leverage and reuse a contract all of their own with, at the time, Molina, now Gainwell. And I've got Gainwell here to keep me honest, so if I'm saying anything too off put here, but no, that's my understanding of it. So.
Yeah, I just want to point something out that always excites me is that the integration started with the collaboration. It started with people talking to each other and being willing to partner before the technology piece came into play.
And I'd also like to add, I'm going to be a bit boastful here, but it allowed the U.S. Virgin Islands to have the first U.S. territory to have a certified MMIS system. The 3 Pacific Island territories, they do not have an MMIS system. Puerto Rico, I think within the past couple of years, they do have a certified MMIS system as well. And we are also having conversations with the 3 Pacific Island territories to hopefully, embark, endeavor on a leverage and reuse relationship, because we're able to transmit data by TMSIS, or Transform Medicaid Statistical Information System, which on a monthly basis we submit our provider enrollment, member enrollment, claims data to CMS on a monthly basis. And that's a part of the goal to be able to obtain state-like treatment, where our Medicaid programs in the territories will be treated like the states, i.e. have open-ended funding versus capped funding.
And, oh, sorry. I was good. Okay. I was there when, wow, that sounded like a history, like I was there. I was there when the CIO at the time in West Virginia came back from meeting with the governor at the time, which was Governor Manchin. And they came into the room and they said, so we're going to the USVI. And we're like, great, let's go. And that was in December of 2009. So the partnership has been a very long partnership. There's been a lot of changes through that time from then until now. But one thing that has stayed consistent through all of the leadership changes, through all of the interactions, is the commitment to keep it going and to make the benefit stronger and stronger and stronger each and every year. And to that point, can the panel talk a little bit about some of the maybe specific examples you may have? I know we had the visit where the USVI team visited West Virginia, and we have a team now here visiting the USVI, but what is that specifically in some of the areas where it has been the greatest benefit? And that can be anywhere from technology to the people, the organization, kind of take it anywhere you like.
I'll just do I'll start off with the process portion of it. How do you improve processes and making it better for really the patient that we serve? And I think that if we look at it from process oriented, how do you do it better, faster, stronger, however you want to do it, so it ends up being better for the client, is I think one of the biggest things that I've gotten out of it. And we do have actually Chris Finch, who was Commissioner of Human Services in 2009, so I'm sure he can rein in on something during that time frame as well. But Gary, you have?
Yeah, well, I was, just to add to what you said, claims were processed by paper prior to that. And providers would have to wait sometimes almost a year to receive payment. So in some instances. And so, Dr. Bacot and others were very happy that we were able to implement this system to operationalize the processing and payment of claims. Outside of the sometimes funding challenges, and that's from a local level, claims are processed and paid minimal twice a month. So once everything is working and the stars are aligned, those dollars get pushed out into to the providers, where they have to pay their staff. Their staff have to go to the grocery store, pay for child care, and other things to keep funds and dollars flowing in the economy. And last fiscal year we spent $104 million for providing services to our members. And the year before that, we spent $90 million. So it's continuously increasing. So I'm sure this year we're going to have a higher number as to the number of dollars that the Medicaid program has pushed into the community for those dollars to circulate here.
So I'll take a little different spin on this. So, knowing that, as I said earlier, needing to modernize our systems and what have you, but this partnership and getting Gary and his team what they need now, but also working with Gary, on the other side of the room, saying, okay, what do you need now that we don't have? Let me help you get that. Let's work through an RFP approach. Let's work through all the specs. Let me help you get that, and then let me leverage that from the VI. Because I'll be honest, West Virginia is known for giving things away, but we very rarely leverage anything back. And a lot of that has to do with our procurement rules, and I won't get into that today, but we're slowly changing that concept, right? We're getting away from this traditional RFP approach, trying to do more cooperative agreements and other contract vehicles that are out there. But truly, sitting down with Gary and his team and saying, okay, here, this is your as is now with your current systems. Is there anything that you need new that maybe we don't have? And if we do have it, fine, we'll have a conversation about that as well and get it for you. But if we don't, then let me sit down, and I think we've kind of used this unofficial term like a technical advisor or whatever, but I mean, that would be awesome, right? Because to me, we can use each other, for lack of a better phrase.
As you were sharing that, I was remembering probably one of my favorite presentations that it was at one of the Medicaid conferences, and the states and territories are asked to bring a poster presentation and then speak about that with the other states and the attendees in the room. And one of the presentations that the USVI did with West Virginia's support as well was, one of the favorite questions we get all the time is, what does West Virginia and the USVI have in common? And why are you partners, and how does that work? And there's a lot of curiosity around it. And at the end of the day, there's a lot of things that are in common. And I just would like to ask the panel, when you're asked that question, what is your response? I'm making you think?
Well, so here's the thing, right? Leading up to this trip and knowing that I was going to have to be up here and talking through this partnership, I got to think a lot about both West Virginia and the Virgin Islands. And two things came to mind, and I mentioned this to the group at lunch. So you all are a very resilient people. West Virginians are very resilient. We have seen disaster after disaster. We've all different types of crises. Even a water crisis of all things, where people lost their water due to some chemical that had got into the river, where the water filtration system was. But you all are also community focused, and you come together in times of need, and that's exactly how West Virginians are as well. And I know our slides didn't show, but there was also the pictures that Nicole had put up there of your all's island, and then we have the New River Gorge area, and the pictures are rather similar in nature when you look at them. So I definitely feel the very similarities amongst both places.
I think it's a development of trust over the years, and so with CMS and the changes that have come, it allows for two perspectives versus just one. And so I think that mishmash and yin and yang, however you want to put it, is best, because it's definitely not the accents that are the same. We're definitely not there. Definitely not that part of it.
I'm getting better.
Yeah. But I think that if you look at it from a yin and yang kind of thing, and the two heads are better than one, but because it can be it could have been any place, right? But if you're so ginormous, how is that going to help, right? Because can you really relate to a place that has a smaller population? So what can we take well? What can we do well? What can we do not well? But for us, I think that was the trust that's been developed over a period of time. And we talked about that very beginning. I think Dr. Ford spoke about it. Trust is what you have, and if you don't have that, then I don't think it would have worked. So regardless, West Virginia, we developed that trust in the beginning.
I just want to say that the thing that excites me the most when I look at the partnership is that you're not alike, not necessarily, and you don't need to be. And you may have learned more about each other over the years, but when it started, you just had two governors that decided we are like-minded, and so if we're willing to lock arms, let's figure out how to do this. And if you think about being from a federal perspective where you're sitting responsible for a country, I'm not going to pair up states and say, Maine's a little bit like Vermont. California is a little bit like Oregon. What you want is to reach out to leaders, and all of us are leaders. And so as a leader, you have a responsibility to figure out what works for the good of the people that you serve, as opposed to standing behind the differences that you have personally, right? So that's what I think is groundbreaking about this partnership. So that's why we're sitting over here. We just want you to see what's happening over here. This is the partnership. You got Brandon, and he's talking with his West Virginia twang. So that's how it's supposed to look. That's actually how it's supposed to work when it works, is that you're not supposed to first figure out, does it have to match? You're supposed to figure out that you both have a need. And so I have always been extremely proud of the leaders who started it and the leaders who keep it going. So kudos to all of you.
I just want to add one final thought. You know, as I was just listening, so I'm going to go into my little local twang then. Since Brandon talking like a West Virginian, I'm going to talk like a Centurion. But anyway, you know, one thing that we are similar is, as Brandon mentioned, the community. I was pleasantly surprised when I visited West Virginia and how welcoming the people were. I'm talking about strangers. I'm not talking about the people who I went to visit, but the people walking on the street. You know, I'm not accustomed when I go to the States, people telling me good morning and good afternoon. That does not happen. You know, you go to New York or you go to Chicago or, you know, Maryland, they don't say you walk in an elevator, say good morning to people and watch you like you're crazy. You know? West Virginia folks walking by me telling me good morning, good afternoon. I'm like, what? Okay. I thought I was back home. So that's what I really appreciated, and then also the staff as well, just so welcoming and warm. It was a very pleasant surprise visit for me.
So Gary, we pay our people. When new people show up, we're like, okay, at 4 o'clock, he's going to be walking down the street.
Just so you know, I've taken the good morning, good afternoon, good night. I take that back too. So I do that now wherever I go. So I pick up, I think I can say one word in St. Tomian, but I won't embarrass myself. So and you can ask me later. I'll say a couple words. So I don't know where we are time check wise. I don't know who my time check person is. Excellent. I was told nothing, by the way. So just, okay. So we'll just keep going until somebody kicks us off the stage. So we've talked a lot about history, how we got here, fast forwarded to today, and where we are. Talking a little bit about the future. What do you envision the partnership? Where do you think it can take us, and where do you think it can go, or other ideas or thoughts that you've had of where the can level up? In other words, the partnership.
So from a Medicaid perspective, in that West Virginia has begun the process of modernization, I see that opportunity for the Virgin Islands as well to leverage that opportunity. I also see the benefit in the continuation of the peer-to-peer visits. It was very beneficial and helpful for us to be able to work on establishing, improving business processes, policies and procedures, but then also preparing us for, as I mentioned this morning, for the provider enrollment application, where our provider enrollment is going to be operationalized, claims processing, the electronic visit verification to improve on our personal care attendant service program, and then also, as we look and analyze, expanding our benefits to include home care-based services and or long-term support services. Having your technology to be able to collect all this data. We're currently, I didn't mention this morning, but we have a change request. We're working on implementing care coordination. That's going to be huge. That's going to align very well with the implementation of the health information exchange. So all of those things, while West Virginia is on that journey we want to, be able to go on that journey with them.
Yeah, so I'll just add, I mean, from day one, when we started this modernization concept and truly looking at what we have and what we need and trying to meet all regulations requirements of both federal and state mandates, I went to the team, and including the Barry Dunn team, and said, as we're building these technical specs, all the requirements for an RFP, I want Gary and his team in the room. I want them to be on the call. I need them to have input on what we're doing, because this contract, I truly want it to be a partnership contract. I want it to be something they can easily leverage to its fullest benefit. And with all of the changes coming down from CMS, where now, TMSIS, they look at TMSIS data very closely to see, where are we at, and that impacts our funding, all the way down to now we have streamlined modular certification, and knowing that we're getting ready to go through one of those now with our EDS, all of that knowledge that we're getting in these processes now should and would benefit, Gary and his team. But yeah, I mean, honestly, from day one, I've just said, I want him to be a part of any conversation because it makes sense. It made sense in 2009 when the two governors had a conversation, and it makes sense today.
I mean, maybe our governors need to get together again. I'm just saying that might not be a bad idea. Just
Is
to
he
kind
here?
of bring
Did he
it
come
full
back?
circle.
I would agree.
I think futuristically speaking, it is in our best interest, and I hope that West Virginia it's mutually beneficial for that. And I think that, in that relationship, and as we're building it again and looking forward to the future, everything that Gary had said recently is going to be, first and foremost. But that process-oriented aspect of things is still going to be my maximum number one thing.
I would like to see the creation of a leverage and reuse playbook. I would also like to see, if you think about risk, the entire Medicaid population for the nation, and if you were to risk stratify it based on who is of the most urgent need for an intervention, the people who we have the least amount of data on have the highest amount of need. And so I would like to see us continue to get them into the system. And so if I were to go around the country as an itinerant preacher, I'd probably start in the Pacific Islands and come back up this way to just say there is a need for a larger investment in leverage and reuse. I was really excited when I came to Gainwell to know that they already had experience in it. Because in my previous job, I didn't pay attention. People think I did. I didn't pay attention to what vendor was doing what. You focus on the state and the people. And so when I got here and I learned about this, I was really excited about it. And so creating, like you guys going on the road and sharing why this matters and why it works for the benefit of, using the Medicaid money more efficiently, upping your credit score for how, when you get money, what you do with it, right? To me, that's the value proposition there.
And if I may, Nicole, I'd just like to add, right? You've heard TMSIS mentioned several times. I'm going to do some more boasting. The Virgin Islands is in the top 3 in the nation for data quality. It's CMS receiving their data. And we continue to be green as far as that is concerned. Green meaning you have green, yellow, and red. Yellow, for project managers out there, you guys know what that means. But green is awesome and excellent. So the VI, it gets mentioned on a national basis regularly. Data quality, the leverage and reuse partnership with West Virginia, and then also the partnerships with all of the other territories, Puerto Rico, including Puerto Rico, and the 3 Pacific Island territories.
So I'm going to make one comment. So the VI's TMSIS color was a driving force for my leadership to say, we best be green. So that was also a driving factor to me going back to the Gainwell team and having to truly understand the differences there, right? Because we have a huge managed care population, so there are some differences around that. But it didn't stop me from saying, you know, this is my job. We've got to be green. And I am happy to say that we were green and blue. They changed the color to blue recently for several months, and then here recently we've kind of transitioned back to yellow. But no, I give people a hard time. I'm like, you know, we're partners with the VI, but they're green and we're not. I don't understand. There's a problem there.
Thank you for that support. That's what's given us. See, you want to know what we're getting from West Virginia? We're green. That's what we got. Thank you for that.
So a little off topic, but one thing I noticed about the partnership are the sock choices on this side of the stage and the shoe selection on that side of the stage. Yeah, like, it's really fabulous. I don't know if everybody can see that, but it is. Who am I? Do we need time check?
Want to ask any questions, maybe, Nicole? Any questions?
What do we got?
We have 5 minutes.
We got 5. Okay. Final thoughts. What would you want the attendees here this week to take away from this, or how can they learn more about how they can, in whatever departments they're working in, or the vendors that are here, optimize a leverage and reuse partnership?
So, yeah, I mean, you know, I would like my colleagues in other VI government agencies to explore that, you know, with your federal partners, but then also, you know, your agencies across the nation. You know, I base my success on relationships that I cultivate and develop. I don't believe in reinventing the wheel, because whatever it is we are trying to do, someone has done it before, and it makes no sense for you to go and try and create something new when there's something out there already working. So, you know, that's what I'd like to leave the audience with.
So West Virginia's perspective is, honestly, as long as I'm in the role I'm in, I want to partner with any and every state that we can. You know, I take it to heart when CMS and other federal partners say, you know, we've paid for it once, why should we keep paying it over and over and over again? And that's been my argument back to our procurement leadership in West Virginia as to why we can't leverage and reuse from other states. Because again, we are, you know, spending more money because we're unique. And the thing about it is, honestly, we are all unique, but we're all in the same game. So I'm happy to talk with anybody that wants to talk about West Virginia and how we can partner in the future. So yeah.
Departments, right?
Yeah, other departments. It's not just the Medicaid department. I mean, public health, any and all departments. Yes.
I think a couple of things. It's a lot of thank yous, because we do have a lot of providers that are here working with Medicaid and helping our members maximize their health care, and I think that's really important, so thank you for that. We also have a lot of contractors or vendors that are working with us too, and we truly appreciate their work because they've made us a success in moving towards this. And I think futuristically for us with CMS, we have a lot going on, not just within the Medicaid program, but service delivery. We have 2 homes for the aged that we're getting ready to build for 2 60-bed facilities, and we're wanting to make sure that those are maximizing whatever Medicaid dollars we can in order to make sure we're doing it correctly. So I think we have a lot of things futuristically to do. We're always going to have room for improvement, and we always have to keep going for the gold. So, so for us, I just want to say thank you for everybody being here and appreciate it. I know it's the end of the day, and y'all got your smoothie and your espresso for staying in, so I appreciate that.
I guess I would just say the same thing that I said before, which is it's easy to listen to what Gary said about it doesn't make sense to recreate the wheel and think, but we're special and we should have our own customized everything. I think the bottom line is you should do an ROI on that. You know, what is the risk of customization and what does it cost that you could reinvest into the population?
Awesome. Okay. Well, am I still on? Okay. I think that takes us to time. I just want to thank the panel. Thank you so much. And thank you again for welcoming me and others here on my team and West Virginia. So thank you so much, and we'll talk soon.
Thank you to all of you. Commissioner Kazi Gomez, I love that dress. Thank you for bringing a beautiful visual to the stage, waking us up with chartreuse. I also like her shoes. She knows that, and we wear the same size. Guess what, everyone? You made it. And I have a mint in my mouth. I almost made it without doing something really foolish, like having a mint in my mouth. So thank you for being here. We get started bright and early again tomorrow. Please look through the agenda. Again, you can scan the barcode. As we change it, as we update it, it gets updated. There are shuttles that are continually running that have already started coming. Yay to shuttles that are already here. So please make sure you continue to interact, meet, greet. Someone just said it. Part of the benefit of these conferences or summits is the information, but 50% of it, if not 60% of it, is the relationships. So we are very aware of that. So highlights for tomorrow include some really fascinating conversations about AI, the future of healthcare, machine learning, how we're impacted by that. We're going to hear from Juan Louis and Schneider a little bit more about their operations. We've got incredible speakers again tomorrow lined up. So go enjoy, if it's not the sunshine you want to enjoy, go enjoy a cool sip in the shade of something local. For any of you needing to know about shuttle service this evening, please head to the front desk. There's water and juice and snacks at the back. Take them on the road, sit and eat, whatever you need to do with them. We appreciate you. Thank you for day one. One more thing. So thank you again, all, and have a great evening. See you tomorrow. Breakfast, bright and early.